We're back for part 2 of week 3. We're talking about skin changes. Hyperpigmentation, pretty common. It's hormonal, I'm sure. All right. Some women are deeply disturbed by the changes in their breast. Not the size of their breast. That sometimes comes as a pleasant surprise for all those involved. But the fact that their nipples and their areolas like grow in size and become very dark. So for some, they're like, whoa, what's happening here? I don't know, it's hormones. Then you have cloasma, which is like the mask of pregnancy mask. That's a problem for some people. It does go away after pregnancy. There's nothing you can do to prevent it, nothing you can do to treat it. Just get through the pregnancy. Linea nigra is a darkened line, usually goes from the pelvic bone up to the belly button. I've seen it past the belly button a bit. Some people get it, some people don't. I see it more in like darker pigmented skin, but I've seen it in fair skin too, so I didn't have it. I know that. But if you want to talk about what I had, we're going to the next. Striae gravidarum. Huh? But it sounds cool. It sounds like a Harry Potter spell, doesn't it? A little bit? Striae gravidarum. Just trying to make it cool, folks. Stretch marks. Good times. They fade from the dark burgundy color, the ones that I had. It looked like a tiger clawed my stomach. Yeah, doesn't it? Oh, multiply that by about 3. Yeah. Now there's silvery little wrinkly lines, which I will not show you. Striae gravidarum. Good times.
What's the hyperpigmentation? Where's that?
There's all of this is considered, other than the stretch marks, although that's pigment too. All of it is hyperpigmentation,
Yeah, okay.
but the cloasma is a hyperpigmentation found often on the face. Vital signs. Vital signs change, obviously. We go in terms of blood pressure. It might actually decrease a little bit during the second trimester and should return to pre-pregnant rate within the third trimester, after the 20-week mark, or baseline. Blood pressure, though, is one of the signs of a complication during pregnancy after the 24th week. Some people have underlying hypertension. Do you know that some women, maybe some of us, got pregnant earlier in our young adult lives, and we sought medical care because we were pregnant. But honestly, it might have been a couple years since we were at the doctor's office as a young adult, right? We didn't need the yearly physical for school or whatever. Some people, the first time they're really entering the medical care world is when they're pregnant. This might be where we're discovering underlying hypertension, underlying diabetes. So we can't, if we start seeing some of these complications early in the pregnancy, and it's most likely it was already there, we're just finding it, all right? So underlying hypertension is an issue, which we may get complicated during pregnancy. A little bit later, they might have an exacerbation of an already beginning problem. A woman's positioning can affect her blood pressure as well, meaning if she lays flat on her back after the 20-week mark, we got a heavy uterus. She lays flat on her back, that heavy uterus is actually pressing down on her inferior vena cava, causing absolutely no blood to be able to get up from her lower extremities back to her head. It actually increases the blood pressure because our blood is trying to get that blood back, but it's not successful because the weight of the uterus is far too great. However, they seem like they might have lower blood pressure because None of the blood's getting back up to their head, and they're passing out, laying down. This happens like in the ultrasound room quite frequently. Even though they're on a slight angle and they do put a wedge under their hip, sometimes it's just not enough. And I've had women pass out laying down because, yeah, it freaks everyone out. Thankfully, they're already laying down. All you have to do is roll them over onto their side, and they come around pretty quick. Then the dad, you have to get them up off the floor. The ultrasound tech is also not all that happy. Yeah, but anyways. So position can affect blood pressure. We tell women to change positions slowly. Go from sitting to standing slowly. Bend, when you bend over and then come back up, just do it slowly because any major change can throw a little orthostatic hypotension in the mix. Pulse will increase 10 to 15, up to 10 to 15 beats per minute higher by about the halfway point. Respirations increase like 1 to 2 per minute. Now, fetal heart rate, once we start catching that, at about the 10th to 12th week, we can actually hear the fetal heart rate with our little special stethoscope thingies. It's a Doppler ultrasound handheld thing. The reason why we can't hear it on the belly before that is because the uterus is still protected inside the pelvis. That's the only reason. They say there's cardiac activity at about the 5th or 6th week. So if they were doing an transvaginal ultrasounds coming from below, they could actually see the heart beating, which is cool. But we can't hear it through the abdomen until 10 or 12 weeks. Should be between 110 to 160. We would like to hear fetal movement at about the 20th week mark, or maybe a little earlier, where you might hear it when you're listening for the heartbeat, but you can't feel it yet. When the baby moves, we expect the heartbeat to go up. Just like if we are moving around, our heartbeat goes up. It tells me that the baby is neurologically intact, healthy. That heart does change, and if there's any underlying cardiac issues that we know about, we get them checked out. But sometimes this is when they rear their ugly head. It's when there's all those cardiac changes during pregnancy. Another way of looking at it, if you want weight, 50 grams to 1,000 grams, increase to 1,000 grams for the weight of the uterus. The uterus will reach the xiphoid process, and for some, it feels like they've gone past the xiphoid process. Shortness of breath, pretty common. Some women have to sleep in the recliners the last couple of weeks of pregnancy because they feel like they can't breathe if they're laying down. We talked about some cervical changes when we talked about probable signs of pregnancy. All right. Breast changes, this increase in size and the darkening of the areola. All the skin changes we already talked about. All right. It doesn't seem to matter if the pregnancy is planned, wanted, or completely unplanned, unexpected, and not wanted, whatever. Like, it doesn't seem to matter. They could have been going through in vitro fertilization, and then they find out they're pregnant. A very common psychological response to pregnancy is ambivalence. Like, it's finally here. Oh, gosh. It finally happened. So ambivalence is very common. It doesn't mean that there's anything wrong. In fact, that's a healthy and common response, a psychological response to pregnancy. It's just a little unsure, like, oh my gosh, am I ready for this? Or I can't believe it has actually happened, or, ambivalence. I'd remember that. Sometimes it's denial. That's where you ever watch, I don't watch them because I can't stand them, but those, I didn't know I was pregnant. shows, that's denial most often. There's some other physiological things that might be going on with them where, they don't feel movement as much or whatever. But a lot of people who don't find out, don't realize they're pregnant for way long. It could be a abnormal menstrual period where missing a period for however many months is not uncommon. So there's that. But I think a lot of it's denial. All those presumptive signs and probable signs stuff, I think eventually somebody would figure it out. But the issue with the first trimester, or early in the first trimester, is that there's a lack of tangible evidence of the pregnancy, right? We might feel nauseous, or we might feel whatever, but nobody else feels it. Or is that this? Is it that? Hence the ambivalence, I think. When a woman would call me saying, I am very sick, with the nausea and vomiting, I'd give her drugs and then say, well, this is your tangible criteria. Like, now this is a real sign that you're pregnant. Just to try to give them something positive. They never really took it quite as positively as I was trying to hand it out to them, but some were like, yeah, I guess so. Makes it easier. You tolerate way more. Huh?
How soon is my Zofran gonna be ready?
Right, right. Zofran, right. Anyway, some people also are just an unexpected gift, especially for those who have years and years of infertility, and it finally happens. So it's an unexpected gift that they know is they have to hold on to tightly. And I'm sure there's a lot of fear involved if there have been a history of multiple losses as well. It's tough. It's a tough time. And I never know. Some people want to wait to tell people that they're pregnant, until the second trimester or whatever. And I understand that, because the more people you tell, the more people you have to tell if it doesn't work out. But those are the same people. Some people announce it on Facebook. I guess that's perfectly reasonable to wait on Facebook. But if you're not telling your closest friends and closest family about the pregnancy, then they're not there to support you if there was a loss too. So I'm not sure how I would feel about it. But I would certainly want the support of my family if there were difficult times ahead too. So people are going to do what they feel most comfortable with, and a lot of that revolves around that ambivalence in the first trimester. Chapter 4 talks about prenatal care. So we get the woman in. Sometimes we have to confirm the pregnancy, confirm some dates with an early ultrasound. And then their first visit, we're looking at their history. We're looking at both their family history, their genetic history, any surgical history, what their current meds are. Are they doing any other sorts of substances, whether illegal or otherwise? If we want a good psychosocial history. We want to know what support systems they have in place, and if they've struggled with any sort of mental health issues in the past, so that we can be supportive for anything here during the pregnancy. Some people have hazardous exposures that we need to be concerned about and counsel in ways to avoid the exposure. And we discuss exercise and diet habits as well. How does this pregnancy going to go for them? Are they going to work all the way up to the end? How do they want to deliver? What are their plans for childcare afterwards? How do they want to feed the baby? The more information we have about their thoughts and the more questions we ask, the more answers they will have. They might not have an answer when we ask the question because they never thought to consider it, right? So we are asking questions, and if we know the answers, we can, again, just support them. Maybe we can direct them to some reading material or a class in the hospital, anything like that, to give them as much knowledge ahead of time as possible. So they get an initial assessment And they come every 4 weeks, up until about the 28 to 32 week mark. They come after that every 2 weeks, until usually like the 36th week, and then every week thereafter until the due date, and then they might come a little bit more frequently if they go past their due date. This is for a low-risk pregnancy with no complications. Throw a little complication in there, and they're coming in more frequently for monitoring and more close monitoring more than anything. What's pretty cool, I think, is once the pregnancy is out of the pelvis and now in the abdomen, one of the first things we do is we measure their belly. And they come sit on the table, we have them sit back or lay back, and we measure from their pelvic bone up to their fundus, to the top of the uterus. Nature has it that the number of centimeters from the pelvic bone to the top of the uterus should match the number of weeks gestation. That's pretty convenient, isn't it? It could be off by a centimeter or two. But if it's off by a significant amount more, we'd worry about, okay, I am 28 weeks pregnant, but I'm only measuring at 22. What's going on? Is the baby not growing the way they're supposed to grow? And then if I'm 28 weeks pregnant and I'm measuring at 32 weeks, or 32 centimeters, are we getting a little too big? It's not about weight gain in general, it's the size of the baby. We're kind of taking out the other weight issue. So that's a pretty low-tech way to keep track. So low-tech, in fact, anyone can do it, right? And so maybe you'd want to remember. Initially, we're going to probably do a pelvic exam, a speculum, bimanual, bony pelvic assessment. We just want to tell if the doctor or practitioner will probably try to figure out if there's adequate space to get a baby out. This might be the first GYN exam for a patient. So, got to keep that in mind. Again, this might be the first time a young adult enters, really, healthcare. We're going to determine a due date. EDD is estimated due date. Sometimes you'll see it as EDC, which is estimated date of confinement. Just to confuse you all. LMP is last menstrual period. So again, we're going to get medical history, we're going to do a physical assessment, we're going to get baseline weight, vital signs, pelvic exam. We're going to do a pap smear if due. I repeat, a pap smear if due. Because it's not contraindicated to do a pap smear when pregnant. And we want to encourage regular exams. And again, I don't know about you, but all of those routine, like annual things we're supposed to do, if it's just to check to make sure everything's going well, maybe they aren't quite so annual, right? So if we get them there, they're motivated to be in the GYN office because they're pregnant, we're going to grab them and we're going to do all that routine recommended annual workups, including the pap smear, if due. We're going to do a bunch of lab work too, and we'll talk about that. We're going to get a weight. We're going to get a blood pressure. Every week, or every visit that they come, we have them pee in a cup. We check that urine for glucose and protein. Every week, or, every visit. After the 10th week or so, we're going to start trying to hear the fetal heart rate. We're going to measure fundal heights, we call it, from the pelvic bone to the fundus. We're going to ask about and try to feel fetal movement after a period of time, 20 weeks or so. And we're going to talk about self-care. Some of the lab work we're going to get at first instance varies, per doctor's office. But we're going to get a CBC. We're going to find out what mom's blood type is. We're going to get an antibody screen too at the same time. Again, we want to know if she's Rh negative, right? So that we can counsel her on the need for RhoGAM later in the pregnancy and after delivery possibly. We're also going to check her antibody screen at that place. If for some reason she had a baby and she didn't get RhoGAM before, if she has the antibody for the Rh positive baby that she had, it's going to show up in an antibody screen. If she did receive RhoGAM, like early, like maybe she went to the ER with some bleeding like 2 weeks before and they just gave her some RhoGAM just in case, that'll show up, but we'll see that it's from the RhoGAM and not actual antibodies. We're going to check rubella. We're going to check hepatitis B. We're going to check RPR, VDRL, which is syphilis, HIV, and we're going to do a urinalysis and culture and sensitivity. The state of Connecticut mandates 2 HIV tests during pregnancy. Yep. Because we can prevent transmission from mother to baby if we know ahead of time. That's how important the state of Connecticut takes it. So if the patient comes in, maybe she didn't make it to the last HIV test for whatever reason. Maybe she's delivering earlier than it was scheduled, or maybe she failed to show up. We're drawing it in the hospital upon admission there. So it is mandated. Did I mention pap smear too? So that's good, right? We're going to do a gonorrhea chlamydia culture. For some, we'll do a hemoglobin electrophoresis. Some might have my mother's father had sickle cell anemia. I don't think I have it, but I've never been tested. We might do a hemoglobin electrophoresis on them. If there's something in their CBC, there's some indicators that might warrant a hemoglobin electrophoresis. So we're just following up on any abnormalities in either family history or initial lab work. We're going to offer and counsel a woman on getting a cystic fibrosis screening. People know that they have cystic fibrosis, but they might not know if they're a cystic fibrosis carrier. So some women find out they're cystic fibrosis carriers when they get a cystic fibrosis screening during pregnancy. So, okay, I'm a cystic fibrosis carrier. Now what? Well, we counsel the father of the baby to get screened. If the father of the baby is a cystic fibrosis carrier, now we're looking at risk. Now we're looking at 25% chance the child will have cystic fibrosis, because you need to have both contributing factors, right? So you do the little square there and get 25%. If dad is not a cystic fibrosis carrier, then the mom doesn't have to worry about it. She may pass on to her child that they are a cystic fibrosis carrier, but the child will not have cystic fibrosis. Does that make sense? So it's a big one. First trimester, we have some screening tests for Down syndrome, chromosomal abnormality type tests that we'll go into more detail a little bit later. We'll offer them. We'll talk about them. Insurance will pay for some, and some they won't. And it all depends on where you fall in terms of the risk category. If you're 35 years or older, they'll pay for more. If they'll pay for the initial screening, and if you are found to have a higher risk for anything, they will probably pay for more specific testing. So the chromosome anomaly screening is still completely optional for there wasn't as much when I was pregnant, but I chose not to have this screen. Thinking back, I wouldn't have done anything differently, whether the screen was positive or negative, but I suppose if I wasn't a stupid kid, which I was at the time, no, not really, but I could have been prepared for whatever the screening result told me. Maybe I would set up care for my child if I needed to go back to work, something. So there's definite value in these screening tests. It doesn't mean if your child is found to have Down syndrome, you're not going to carry on the pregnancy. It just means you're going to be prepared for whatever you have. Does that make sense? I think that didn't make sense to me 27 years ago. I'll pass that on to you. A lot of centers offer what we call a first trimester screen. It's a simple blood test. It's actually a finger stick. And they do an ultrasound, very specific ultrasound, early in the pregnancy. And it's like 10 to 13 weeks pregnant. So right at the end of the first trimester, they're measuring the nuchal fold, which is the neck, the area at the back of the neck, which is very, very small, but they're measuring that. Between the serum screening and this ultrasound assessment, they are coming up with a basic risk for Down syndrome. Now, a little bit further along, between weeks 15 and 20, we can do a quad screen. It's a blood test only, and it's called quad screen because there are 4 different markers that they're looking at. Again, just more risk screening for Down syndrome and open neural tube defects like spina bifida and anencephaly.
The first one was a finger stick only?
Mm-hmm.
Okay, thank you.
Other tests that we will do, we might do a glucose check, not might, we're going to do a glucose challenge test on all pregnant women. Without any risks, they'll get it at the 28-week mark. If a patient comes to us with a higher BMI, some doctors say a BMI of greater than 30, they're at higher risk for having underlying diabetes outside of pregnancy. So we'll probably do a glucose challenge test on those patients at 16 weeks, just to see if they have diabetes. If they have diabetes at 16 weeks, it's not pregnancy related. They have underlying diabetes. Some, again, it varies by practitioner, but some women with a higher BMI might get a hemoglobin A1C with the initial lab work too. And if that's elevated, we take it from there. So otherwise, at the 28-week mark, every pregnant patient, no matter what their weight is, gets a glucose challenge test. Fun times, no? Who remembers their glucose challenge test? Huh? Yeah. You drink a very sugary drink. Tastes kind of like
orange fluid.
like ass. Is that what something said? Yeah.
Soda without the fizz.
Right. Soda without the fizz. That's it. Yeah, like flat orange soda with no. But yeah, I remember it.
Thick.
Yeah, good times.
Nectar thick, flatworms in them.
Yeah, yeah. Some have like different flavors. I found that if we refrigerate the stuff, it goes down a little easier, but warm, flat, sweet syrup doesn't sit well on a already upset kind of stomach. Anyways, it's 50 grams of sugar. They take that, and an hour later we just do a glucose test. And if it's higher than, say, again, it's physician specific, but either 135 or 140. If it's higher than that, we need to do a little bit more testing. We'll send somebody for a 3-hour glucose test That's fun. That's good times right there. So now I'm already stressed that I might have diabetes. All right. Now I am hungry because they make you come in completely NPO after midnight. All right. Because the first thing we're going to do is get a fasting blood glucose. Now he's going to take 100 grams of the flat, warm orange soda. And if you don't give it back to me, which some patients do, which means, bye-bye, you go home and let's try this again tomorrow. Oh. Anyways, 100 grams within 5 minutes, by the way. You have to, take that down. 1 hour, 2 hours, 3 hours after that ingestion, we're checking their sugar. So we're watching their body metabolize sugar over time. At a minimum, 2 out of 4 of those numbers have to be elevated. And if they are, it's gestational diabetes. We diagnose it at that, and we get on them right away. If we can get them over to the dietitian's office that day, we will, all right? We send them there. We want them to learn about diabetic diet and what exactly they should be eating and what they shouldn't be eating and how much of this and how much of that. We teach them how to check their blood glucose. All of a sudden, they're checking their blood glucose 4 times a day, fasting and 2 hours post meals, all right? And then we're bringing them in like a week later, and we're looking, how did the diet change your blood sugars? If it didn't change it enough, we counsel them, we do what we have to do, we might send them back to the nutritionist. We're on them like nothing. We're very careful, all right? We do not wait a long time. If they cannot control their blood glucose with diet, for whatever reason, they're on insulin. And it's not a threat. Some women's blood glucose is not as controllable as others. And it has health consequences naturally for the mother, but honestly, it's the baby we're most concerned about, because uncontrolled diabetes on a fetus can kill them, plain and simple. There's higher risks of stillborn, and we're talking 40 weeks along, a baby can die in utero, okay? I remember my aunt, who is now dead from diabetes complications, and I was young. I think I was like 5, maybe between 5 and 7. I remember, probably because we were really excited because she was having a baby, and then the call came, and it was somber. And at that age, I remember that at 40 weeks along, her baby had died. So she had to deliver her baby. Yeah, but I remember that. Of course, I didn't know why or anything like that. But looking back, it was probably uncontrolled diabetes, because she was very bad diabetic later in life. So that's what happened, 45 years ago. We don't want it to happen again. And so we seem like we're hard asses about it, but it's because we want to get things under control as quickly as possible, keep it under control for the health of that baby and the ongoing health of that mother. But it's really about the fetus, to be honest with you. Anyways, I move on. Rogam, going to be given at the 28-week mark for any Rh negative patient. Some women say, I don't want Rogam. My husband's Rh negative. There's no chance my child can be Rh positive. Okay. Give me a verified actual lab slip telling me your husband is Rh negative. That's the only way a doctor will allow a woman not to get Rogam. Because it's not on my watch. You're not going to become Rh, iso-immunized on our watch just because you don't want a shot. So we will waive it if the father of the baby is Rh negative. Groupie strep culture. We talked a little bit about GBS back in the first week. That is done at the 36-week mark. And it's done on all patients. There are no risk factors for GBS. It crosses all socioeconomic, ethnic ethnicities, I guess, it's any status we have, our GBS happens everywhere. It's not a transmitted, it's not like a sexually transmitted infection, so it can happen to anyone. So the only risk factor is that they're about to have a baby in about 4 weeks. So 36, 37 weeks, they're getting the GBS culture. It's a rectal-vaginal culture. There, I talked about the blood glucose. For some reason, I wanted to talk about it again. I don't know why. Maybe I'll pull that slide out with the next edit. Oh, here's your pictures of the vaginal rectal culture for anyone interested. Right. We have a captive audience with these patients coming in to every 4 weeks, to every 2 weeks, to every week. So we're going to do as much health promotion and education with them as we can during their time. So we're going to talk about just healthy lifestyle changes. If we can get to them before they get pregnant, all the better. If a woman who smokes and has a couple of cocktails every night wants to get pregnant, we're going to be counseling her ahead of time. You might want to back off on the smoking cocktail habit so that once you find out you're pregnant, you're not stuck with having to make that sudden lifestyle change. If we can get them nutritionally to a great place prior to conception, all the better for pregnancy outcome. We're going to strongly encourage the flu vaccine in any pregnant woman. As long as it is not the live virus, we want every pregnant woman to get a flu vaccine. Every pregnant woman and every student nurse. Right? And every pregnant student nurse, you have to have 2. Pregnancy complicates the flu. Flu complicates the pregnancy. So, if we can avoid the flu during pregnancy, all the better. The Tdap vaccine is another one that we're going to strongly encourage in the 3rd trimester. Even if 2 years ago they had the Tdap vaccine with their last pregnancy, we would encourage repeating the vaccine during the 3rd trimester. We found that there's some immunity that might get passed on to your fetus if you have it done.
Do you do the flu for the 3rd trimester too? Or
No,
just
anytime
start?
during the pregnancy. Yep, as soon as the flu season begins. Exercise, they should really they can maintain their exercise if they're already active. If they're not active, we would encourage like 30 minutes a day, but it's not any time to start training for a marathon. All right? But if you are a marathon runner, maybe back off on the marathon thing. Half marathon, right? I don't know. So you can maintain your level of activity if it's a healthy level of activity. Once that uterus is no longer protected in the pelvis, you have to worry about abdominal trauma. So I would avoid soccer, wrestling, football, gymnastics maybe. I don't know. So there's some things you might have to back off on during pregnancy simply for your health and well-being. But we definitely want 30 minutes of moderate exercise, which might just be a walk every day. Avoid hot tubs and saunas. Any increase in body temperature can affect the growth of the developing fetus. 2 to 3 liters of fluid a day. Caffeinated beverages don't count, nor does vodka. From some foods have liquid in, and that's okay. But that's a lot of extra liquid for some people. And so we stress the importance, especially, during the summer months when you need even more than that, if you're overheated. And then let's let's get them into classes. But talk to them if they're not willing to that. Talk about the physical changes upcoming. Talk about the emotional changes that are common, and get them to know what's normal and what's not normal, and what they can expect and what they should reach out for. Some people say they felt like they were like constantly having PMS. It's emotional ability, I guess you'd say, hormones. That's what it's about. But your body's, the pregnant woman's body's doing a whole lot, and there's a lot of extra things going on, emotionally, physically, hormonally. They need more rest. They are scared. They're ambivalent, right? They are they're already stressed about going back to work after the baby, and they're only 4 months pregnant. But these are the things that people think about. So it's really important to encourage them to express their feelings, and to reach out if those feelings are overwhelming or extreme. But 1 minute they could be laughing and completely joyful, and the next minute they could be crying and rage-filled, right? So this is a good conversation to have with the patient, and if you have the patient's partner anywhere nearby, pretty good conversation to have with them too, because they need to know that this is normal, and not to make the problem worse by adding to the problem. I don't know if that's possible, but if they know, then they are armed with the information and can be helpful, at least not harmful. Did I mention ambivalence? Yeah? All right, good. All right. First trimester is a lot of reassurance, a lot of counseling on, the different tests that we're going to do, that sort of thing. And we got to talk to them about common discomforts and different strategies to help with them. Talk about lifestyle changes. Try to get them on the right track in their healthy pregnancy. In the second trimester, we're going to start talking about breastfeeding and different discomforts of, advancing pregnancy. We're going to talk to them about specific complications of later pregnancy so that they're aware of signs and symptoms they need to report. We're going to talk to them about fetal movement and what they should expect, and how to kind of keep track, and what they can do if they note a change. We're going to start talking to them about a birth plan. How do they want to deliver? Get them set up with birthing classes, if that's it. Get them starting to practice whatever technique they want to utilize, whether it's the breathing exercises, or some people want to do hypnobirthing, that sort of thing. Well, hypnobirthing is awesome, but it's not something you just read about and can do during labor. It takes a lot of practice ahead of time with the patient and their support person. So some of these things are great, but they just need preparation ahead of time. In the third trimester, again, more childbirth preparation, when to call the doctor, what's normal, what's not normal, what's a sign of a complication, that sort of thing. What are the signs of labor? Get them talking about that. What to do when your water breaks, what to do when you think you're in labor, when to call, where to go, that sort of thing. Third trimester, we're going to be talking more about kick counts. So now fetal movement is very obvious to both the pregnant woman and anyone who is nearby. Having their hands on their belly. Like the lady in the deli, touching her belly without permission. No, I'm just kidding. So we want them to count a couple times a day. Just, take a moment or an hour and count. We would expect that the baby moves at least 3 times in an hour, all right? And if it's less than 3 times, or they haven't recalled feeling the baby move at all for 12 hours, then they really need some further evaluation, okay? Sometimes it's just resting, taking a nice big, maybe having a snack, drinking a bunch of water, laying down on their side and being mindful of the movement. Oh, yeah, it was moving. I was just busy and didn't notice. Or I needed to take a big glass of water, a snack, and lay down. For any complicated or high-risk pregnancies, in the third trimester, we start non-stress tests, biophysical profiles, ultrasounds, that sort of thing. We'll talk more about them after a short break.